Okay. Well, good afternoon to everyone except Dave, who is still in the morning time in the state of Washington. But I want to welcome everybody to today's webinar. We're really excited to have Dave Chase with us today and talk about empowering community-owned health plans insights from the last decade. We want to welcome our members from the Kansas Business Group on Health, as well as our members from our sister coalitions in Oklahoma, Houston, and Kansas City. I also want to thank our local sponsors, not only for today's event, but for all of the events that we're hosting in 2020. And those include Blue Cross Blue Shield of Kansas, Entrust Bank, United Healthcare, and Child Start. We are just a few housekeeping rules. We are currently, or most of you, all of you are on mute. And so we would ask that you pose your questions to Dave in the chat box, which is located in the center of your bottom screen. And when Dave is done presenting, we will have, I think, plenty of time for question and answers. And if we don't have enough time, Dave has agreed to try to answer the other questions offline later. Anyway, Dave Chase is the creator of Health Rosetta and co-founder of the Health Rosetta ecosystem, where he leads the vision for Health Rosetta, which is to empower community-owned health plans. Health Rosetta's blueprint and platform powers the health plans of your dreams. High quality, trustworthy, local, affordable care that you thought had disappeared forever. From caregivers you know and trust, they free up compassionate, well-trained, community-based caregivers to rediscover love in medicine so they can do what they have always been called to do, serve their patients, not just in disease, but toward their fullest health. A trusted and sacred caregiver-patient bond is built through transparency and openness that equips and empowers patients wherever they can best achieve their unique health goals, at home or in any setting, best optimizing their well-being. By avoiding the 50% wasted healthcare spending, they can ensure the caregivers have the independence and resources to address the psychosocial and medical issues their patients face. Human-centered health plans restore health, hope, and well-being. Through best-selling books and The Resident on Fox, where Dave serves as a consultant, collateral damage from the extractive era of healthcare is highlighted, as well as the tremendous successes and opportunities with Health Rosetta type health plans. Dave's books, writing for various media outlets, TED Talk and TV film have reached over 10 million people with the goal of informing, enraging, empowering, and activating a broad grassroots movement designed to restore hope, health, and well-being to our communities. Dave received the Health Value Awards Lifetime Achievement for Health Benefits Innovation at the 2020 World Healthcare Congress. Dave co-founded Avado, which was acquired by and integrated into WebMD Medscape and founded Microsoft's 2,028,000 partner healthcare ecosystem. Outside of work, Dave is an oxygen-fueled mountain athlete and volunteer high school track and cross-country coach. Once upon a time, he ran coach himself and was a Pac-12 800 meter and 4x400 competitor. Most importantly, devotion to faith, family, and friends underpin a desire to be a servant leader to the 4 million lives and growing, stewarded through the Health Rosetta community. We are really honored and so appreciate Dave's willingness to do this. He is really a very highly sought after and nationally renowned author and everything else I just said. So anyway, Dave, we really appreciate you doing this for us, and I'm going to turn it over to you.
Great. Well, thank you so much, and I appreciate the opportunity and looking forward to sharing some of the observations, over the last decade. I kind of describe it as a scavenger hunt. I believe that people, and especially Americans, are fundamentally problem solvers, and, we're well aware that there's a lot of shortcomings in our healthcare system. And so I was like, well, who's already figured it out? They might be the outlier, but what can we learn from them? And really the system change approach that we've adopted, which is modeled after an approach that has lifted tens of millions of people out of poverty in India and is remaking a key part of the food system in the US. Really the essence of it is you find little microcosms of success, and then the real challenge becomes how do you apply a little business know-how, technology, and maybe some capital to massively replicate that. And that's really our focus. So I'm going to share some of what we've learned over the last decade, and particularly over the last few years while we've really been focused in on earnest with Health Rosetta, which is this open source blueprint. And as Shelley mentioned, really the heart of what we're doing is is about empowering community-owned health plans. And we define community in the broadest definition of community. A community can be an employer, could be a union, could be a place-based community, it could be an affinity group, but it's really a different mindset that comes to bear that we see some terrific results in. So I'm going to go ahead and jump in and share some of those insights. But first, I want to acknowledge that, we're obviously in a pandemic, and in many ways, the pandemic is showing some of the shortcomings of our system and lack of investment in primary care and public health has made it more challenging. And, it's quite striking. We have incredible clinicians in our country. I don't think any country has more passionate, talented clinicians who are really giving of themselves and caring for us in our most vulnerable moments. Yet, if you look at it, they're only getting 27 cents of every dollar. That's a little bizarre in my mind, since they're the primary value creators and they really truly are on the front lines of this. We're in a war essentially. Bullets aren't flying, the virus is flying, but there's, very substantial portion of the people who have died, and we're approaching 100,000 people just in the US, are healthcare workers. So I really want to acknowledge what they're doing and how much I appreciate their work. And as I've gone around and found these insights, more often than not, it has been sort of particularly physicians who stepped out and said, wait, I'm really frustrated with what's going on. This isn't the best reflection of our humanity. Let's do something different. And that's who I found on this scavenger hunt. And, what we have today is a real imbalance. This is drawn from a study of studies. I'll go into it a little bit more later, but big picture, this was a Robert Wood Johnson Foundation looked at on the left, what actually drives health outcomes. Only 10 or 20% are what some people would call the sick care system, half access, half quality on that. But it's all these other things that, common sense actually drive health and well-being, yet the vast, vast, vast majority of our dollars go to a healthcare system that's not producing great outcomes. In fact, we're at the bottom of the heap in terms of the developed world. We've got pockets of excellence, no question. But on balance, there's a lot of dollars that are not going to what actually drives health and well-being. It's been well known for at least a decade, thanks to PwC and Institute of Medicine, that a third or even over half in PwC's analysis is waste, doesn't add any value. And so I'll come back to that, but I think that's quite striking. And if you look at where do those dollars go? I think we've kind of been in this extractive era where the majority of every dollar actually isn't going towards health and well-being, and as I mentioned, towards clinicians. But even you take a county like I live in, there's about 250,000 people. So all in, a little over $2.5 billion are spent on healthcare. And at least $1 billion of that gets extracted out of our local economy. Where does that go? Fraud. That was something I hadn't thought about. Accenture, FBI estimate as high as 10%. There's an article in The Economist a few years back. They called it, I think it was like the $274 billion heist, talking about the US healthcare system. A lot more going on there than most people realize. There's tremendous rates of misdiagnosis and inappropriate treatment. I have a whole chapter in my book that I'll reference later that goes into this, based on solid data from some of the biggest healthcare purchasers in the world. Really quite extraordinary rates. And then we just have pricing failure. When there's no correlation between what you pay and the value you get, that's pricing failure. And we're seeing a lot of that. Again, I go into that in a lot more detail in my book. And then we have some bloat on the administrative side. I don't have it in this deck, but there's a graph that shows the explosion in administrative headcount over the last 20 years versus clinician headcount, which has largely stayed flat. And then there's some programs that sound good on paper, but some of the so-called workplace wellness programs, what some consider to be the father of that industry, now has a $3 million challenge to anybody who can prove that there's actually a return on investment. It's pretty provocative. But again, there's a chapter in my book that really goes into that, so I won't go into detail. But then again, where the real value is created is in the paying high value care providers. And that's a lot of what we get right when these plans reform. And if you pull back and look at it at a broader community level, I look at Massachusetts. A, I've got data from there, but B, it's kind of a preview of coming attractions. Romney Care was sort of the model for Obamacare. And this looks at state spending on health care, both for the state employees plan and Medicaid. So healthcare costs go up. Even in Massachusetts, you can't increase taxes enough to make up for it. And what does this come out of? These are things that are really vital right now during a pandemic. And we've devastated financing for public health, mental health, infrastructure, human services, education. These are broadly referred to as the social determinants of health. And that's a big part of that imbalance that I mentioned. And meanwhile, I was in Massachusetts a little over a year ago, and it was striking. Even when the economy was robust, students were basically on strike, if you will, complaining about lack of funding. And in Boston at that time, and that same week, there was an article in the Globe, Boston Globe, about half of the schools in Massachusetts had significant levels of lead in their pipes. And as we saw previously, we've crushed funding for education. And during that same month, there were two other articles that were striking. One was that the big health system there, Partners, was announcing another $1 billion medical center. And then there was another article that was an investigation that Massachusetts hospitals had squirreled away $1.6 billion in the Cayman Islands. And then the other thing that was striking, part of the reason I was there, which I'll mention later on my book, is I've been deeply studying the opioid crisis, and what they call methadone mile is literally in the shadow of $1 billion medical towers. So, in effect, we're poisoning our kids and addicting people in the name of an edifice complex. Is massive overbuilding that's happened there. So even though there's pockets of brilliance there, and we're certainly thankful when there's things like the Boston Marathon bombing that, at our best, our healthcare system's amazing, but many times it's not been that impressive. So what have we found? We have this shipping container metaphor that we use, and the blue items are essentially, I'll go into these in more detail, they're kind of the underpinnings, they're kind of the boring parts of a health plan. And what I found in literally over 100, many hundreds of companies and public sector entities that are spending 30% less per capita, in some cases even more, or even more of a savings. And it comes into these areas, which I'll go into more detail. Transparent pharmacy benefits, there's some significant savings there. It's, pharmacy is about 15-20% of overall spend. Major specialty and outliers, this chapter on centers of excellence in my book gets into this. In a given year, 6 to 8% of your members are going to consume 50 to 80% of your dollars. So you got to really get that right. What we call transparent open networks, which is essentially the successor to PPO networks, and then value-based primary care. There's no well-functioning healthcare system in the world not built on proper primary care, and we've basically devastated primary care in our country over the last 20 years. So it's getting rebuilt, can't happen fast enough, but that's kind of the high level. And again, this gets all broken down in our website and my books, which I'll reference, so I'm not going to go into great detail here. But really, there's this 5-step plan to really transform. It spells out local, because this is really about relocalizing health. You know, what's more local than an interaction between a doctor and a patient? Yet we're extracting so much money out of our local economies. And the logos here are just a few examples of some of the companies that we've got case studies for. And this looks at the overall thing. And basically what we found is nothing happens until there's a mindset shift. Many people think that solving healthcare is like solving Middle East peace. You know, they like that solved too, but it seems kind of hopeless and out of their control. And so we really disabuse them of that notion. So that's really this mindset shift, learning how to be liberated from the status quo. And as I go through these 5 steps, one of the key things to note is of these 5 steps, 4 of the 5 are either invisible to the member or are clearly a net positive. It's only the 5th one, which I'll go through at the last, that has a potential for, if you don't do it well, to have a negative impact. If you do it well, it's actually the best of all of them because of the savings. But people are understandably concerned about what some people call disruption to the members. And so we're mindful of that. But at the same time, we're also mindful of the status quo is disruptive. Make no mistake. We are the undisputed world leaders in medical bill-driven bankruptcies. It's 2/3 of the bankruptcies in our country are from medical bills, and 70% of them had insurance. So that's not protecting them. That sounds pretty doggone disruptive to me. What also sounds disruptive to me is 20 years of wage gains have been stolen by the healthcare system. The working and middle class has not seen a net gain in 20 years. Not because employers are stingy, they're spending far more money, but it's all gone to an underperforming healthcare system. So I want to have that balanced view of, yep, we're concerned about disruption, but the status quo is awfully disruptive. And the 3rd leading cause of death is preventable medical mistakes. So what you do is very important here. So that's the first step, the L. The second one is optimize plan infrastructure. This is kind of that blue stuff, kind of the boring stuff, but we publish in the book and on the site a advisor code of conduct, your benefits broker, a plan sponsor bill of rights, a advisor disclosure form. If you're relatively new to healthcare, these are things like they feel like motherhood and apple pie. But as we really dug in over the last decade, it's not the norm, frankly. We find up to 17 undisclosed revenue streams that employers are not aware of. And so if you do this kind of spring cleaning on the plan, you can get some savings there, and that's nice. And that can free up money for things like proper primary care that has some upfront investment but pays back pretty quickly. But the key thing here is it impacts all the other spending. So there are things like, one of the things that innovative employers are doing is doing direct contracting with employers. I'll give you an example later of that. Well, there's a lot of agreements that employers have that prevent them from doing that. And so one of the case studies that we have in this area is Copper State, that logo over on the left. They're about 1,000 employee organization in Arizona, and they were, have been on a big carrier's plan. They were self-insured, so they've taken that step, but without changing anything really about the plan experience. Basically doing the spring cleaning, there's a lot of kind of junk fees that are added in, and lack of review of claims, things like that, that they put in. And they saved $1,000 per employee per year. Thing really of substance in the plan. That's how messed up some of these things can be. So there's opportunity there. So that's the O in local. The C is carve out PBM. A lot of people don't realize that, the 3 big PBMs who are kind of the dominant players, they're Fortune 50 companies. A lot of people in our society haven't even heard of, these companies. And I mean, not to let pharma completely off the hook, but there's not one pure pharma company in the Fortune 50. So that tells you how much low-hanging fruit there is. And you look at some of these organizations I have pictured here, Caterpillar, really the only thing they've done as an employer of sustained significance in their plan was they used their procurement expertise from being a manufacturer and they applied it in this area. And they haven't seen overall healthcare costs go up in a dozen years because they got really smart on that. That shows you the overall impact. State of New Jersey, their state employee plan, in the last 3 years, they've saved $2 billion by getting, they actually worked, the way they do it is quite smart. They actually worked with they got one of the big PBMs to give them a fair price. So it's not like you can't work with the big PBMs if you know how to procure properly. And that's one of the things we educate people on in our community. And then Pacific Steel, I'll mention later, about a quarter of the savings, which I'll reference later, comes in their pharmacy, but I'll go into them in a little more detail later. So that was the C. A is add value-based primary care. This is things like direct primary care, on-site, near-site clinics, virtual primary care. You can get significant savings in a well-functioning, fully actualized primary care like we have in some places in the US, certainly the exception, and the way it is in places like Denmark. Fully 90% of the issues people come into the healthcare system for can be fully addressed in a primary care setting. That's not what most of us experience in this country as we've hollowed out primary care. And so it's getting rebuilt brick by brick. But one of the reasons you get great payoff on this, even though there's a bit of an upfront investment in it, is you can't price gouge on a surgery that never happened. You can't price gouge and do surprise bills on an ER visit that never happened. Most ER visits are not true emergencies. People just can't get into the primary care doc, or they don't even have a relationship. Basically, 75% of Americans don't have a relationship with a primary care doc. So you fix that. And some of the examples I have here, these are companies like Gasparilla Inn, is one of the example, Rosen Hotels. They're both spending 50% less per capita with some of the best benefits packages I've heard of any company anywhere in the world. The pipe trades, that's a union with 16,000 lives in sort of the other end of the spectrum in terms of size, like Gasparilla Inn's, I think they're only like 140 people. The pipe trades union, so there's like pipe fitters and plumbers, sort of like Caterpillar, they just did one thing. They just focused in on primary care. They've been doing it almost a decade. They've only gotten 25% of the members in because 99% of their members are male and most households, women make the decisions on healthcare. So they still have a challenge there. But even though they only just did primary care, just got 25%, they haven't seen their overall healthcare costs go up in a decade. That's the kind of impact you can have even without doing some of these other things. They haven't done the stuff on pharmacy and what I'm going to mention. So that's the A in local, is add the value-based primary care. As I mentioned earlier, there's no well-functioning healthcare system in the world not built on proper primary care. So it's just time to act on that. And then finally, this is the one thing, if you do it poorly, the member can see it. Now, if you don't goof it up, you do it well, like a Pacific Steel and Recycling, they're about 750 people, company based in Great Falls, Montana, 9 states, 40 plus locations. 4 years ago, they were spending $8 million on their health plan. Last year, they closed out at under $3.5 million. And there was no effective change in utilization. How did they do that? Well, they got rid of profiteering and price gouging. And some of you may have heard of reference-based pricing. That was sort of the first step in that journey. And actually, previously, they had tried reference-based pricing and had not worked out very well because it was poorly executed. So if you do it well, it's great. Members, they understand zero. When you say, if you go here, we will waive all co-pays, deductibles, cost sharing, you name it. The only paperwork you got to deal with is a thank you survey after, which some organizations do. Or you can go over here and you're going to get EOBs that don't really explain things very well. You're going to get surprise bills. You're going to get, a bunch of bills, and it's frankly pretty bad experience. It's why the net promoter score for the health insurance industry is the lowest of any industry that I'm aware of, lower than cable companies and airlines even. And so what did Pacific Steel do? They use that reference-based pricing as kind of a starting point. They also have a member champion. So if it's a non-emergent scenario, there's somebody who can help people navigate the system. Navigating our healthcare system is, on your own is probably like trying to climb Mount Everest on your own. You wouldn't go up Mount Everest without a Sherpa. You kind of need a Sherpa, metaphorically for this. And so they use that. And then in the last 2-3 years, they've got 5,000 direct contracts in place. These are, of course, you don't get 5,000 direct contracts unless they're very simple and very fair to both sides. These are 2-page contracts, really simple. And it's been good for the provider. They address some of the pain points the provider has, and then also get a fair price. And this is where you can see some really significant savings. Bennett, here just to highlight one of them that's a really recent one. This is a school district east of, probably between where you are and Denver. It's east of Denver, and it's a rural community. There's only about 100 people on the plan as a school district, and with primary care and then doing this sort of thing, they dropped their spending by over a third. They're the only school district in the region that's been able to give their teachers raises because of that. So some really great stuff that's gone on here. A lot of case studies in the book that I can go into, and certainly if there's questions, I am happy to go into more detail, but I'll keep moving along. And so, I tend to believe, in this Churchillism, that's kind of funny, but sadly sort of accurate, that, Americans will always do the right thing after exhausting all the other alternatives. And we see, this community health plan is this, it's a term I use for this, right? It's not a formal thing, but it's really this ownership mindset versus renter mindset. If, as every CEO I've ever talked to, your employees are your most valuable asset, shouldn't you steward that asset carefully and have that owner mindset versus a renter mindset? And that's really the common thread as I go through these examples. So Rosen Hotels, I mentioned briefly, my TED Talk highlights them. There's a chapter in the book. They've cumulatively saved, the only thing that's really unique about them is they've just been doing it longer than everybody else. While they've grown from 500 employees to over 6,000, they've cumulatively saved over $400 million. That's allowed them to provide incredible benefits to their employees, not only great health benefits, but they pay for their employees and their employees' kids' college education at state schools because of all this extra money that's there. They haven't had to grow. They're debt-free. They were able to stay open through all this pandemic, unlike other hotels in the area, because they were debt-free. And the reason they're debt-free was because of their health plan. And there's other facets to the story that are really amazing. They took a portion of what they saved and they adopted a nearby formerly crime-ridden neighborhood and said, we're going to invest in kids and education. And so they partnered with like the YMCA and Boys and Girls Club for daycare, pre-K, after-school programs. So far, they've funded 450 college educations. Crime went down 62%. High school graduation went from 45% to virtually 100%. The total investment was less than 5% of what they have spent versus their peers, that 400 million. And it's worked so well, they recently adopted a neighborhood 5 times that size. So really incredible, right, what they've done and really taken that community mindset. I mentioned the pipe trades and what they did, so I won't go into that in more detail. Pacific Steel, also mentioned them. They're doing a great job. And if you look at a company like Pacific Steel, they would have had to increase their top line sales figure, their revenue, probably 25% to have the same profit impact as what they did on their health plan. And in this environment we're in, where in many ways health benefits is the last area for companies to modernize, they've done, supply chain, ERP, sales automation, marketing automation, talent management, all these things. Really, the last area to be modernized is healthcare, and so they've done that. Another example up in South Central Alaska. This was formerly a failing kind of Indian Health Service scenario. They're the only two-time winner of the Malcolm Baldrige Award in the healthcare industry. This is a very prestigious award. They call their patients customer owners. It's a very different mindset. Again, proper primary care, proper focus in on social determinants of health, really a remarkable scenario in a very tough environment. And we're seeing this pop up all over the country now. There's these kind of green sprouts. People are taking this ownership. This happens to map where we have accredited advisors in our program. And only about 15% of the almost 1,500 people who've started the process have made it through so far. It's a pretty rigorous process, but they're really leading the way. And, it's surprisingly easier than you might think. The things above, which I go into more detail in the book, and I've touched on, like transparent open networks and value-based primary care, these are in place, they're proven. There's hundreds of examples of them. It's not some ivory tower concept, they're proven. Really just the wrinkle is this kind of community-owned health plan mindset that really comes in. And that's the piece that needs to be added. And if you look at, a good example of this, of how does this happen at the community level? I go back to that system change model where typically if 10% of a sector adopts something, it tips a market, sometimes 15%. Some people say as low as 3.5% in social movements. But if you break down this problem, which is seemingly intractable, and you just look at companies in the 100 to 5,000 employee range, it's actually a sweet spot. They're big enough to be really have the attention to focus in on. Many of them are self-insured, so they can take control of things. And you break that down, it becomes solvable, right? There's over 200,000 of these companies. If you just take 10% of them and divide that into the 775 cities and towns with over 50,000 people, that's only 29 companies in a given area. And what we're seeing in places like Tyler, Texas, there's other examples like in Eastern Idaho and other places, Denver, some good stuff going on there. It's kind of this rule of threes where it starts out you get three companies doing it. Nobody notices, but they're building some track record. They're building some experience, starts to build some credibility. Then you get 9. People actually start to notice. They see it. Some of the provider organizations change some of their approaches at their front desk. There might be some direct contracts. And then when you get to 27, it's game over at that time. You look at a place like Tyler, Texas, the advisor we accredited there, she's having to turn away clients. She had, a good year would be adding 5 clients. She had to stop at 26 because the word's out. When all these employers are spending 40% less and having better benefits because they got great primary care and going to high quality surgery centers and stuff like that, the word gets out. And so it makes it a much more solvable problem when you break it down that way. And, that's only about 5,000 employees, about 10,000 individuals in a target area. So it becomes doable. So let me just go through this a little bit more. I look at it, if you look at the employers I mentioned, a Rosen, a Pacific Steel, a Gasparilla, and these sort, if everybody did what they're doing in the employers area, that would be like a $500 billion recurring stimulus into our economy. And as I mentioned earlier, this, if using my own county as an example, with at least $1 billion get extracted, if we only repatriated 10% of that's still $100 million recycling in our economy. That's an amazing impact. And that's what we're really focused in on. How do we enable that? And to go into that study of studies a little bit more, that Robert Wood Johnson Foundation, this goes into what drives health outcomes. 30% are in health behaviors and a little genetics, diet, exercise, again, common sense, physical environment, clean air, clean water, housing, transit. That's about 10%. Social and economic factors is the biggest one at 40%. Education, your income, is the neighborhood safe? These type of things. Again, common sense. And then 20% in the clinical care. So that's really, if you start there, health starts at home. Doesn't start in a pill, doesn't start at a hospital. It starts at home, mom, dad, neighborhood, community, etc. That's really a different mindset. And we're fiercely nonpartisan in what we're doing, but it's interesting to note that there's a real meeting of the minds around this concept of community-owned health plans across the spectrum. The left really likes the social impact. The right really likes kind of the local control, and the one size that does not fit all, avoiding that. They like the market-based aspect. Really, everybody likes government looking out for people who truly can't afford healthcare, loss of genetic lottery, whatever that might be. Everybody likes rooting out waste, fraud, and abuse. And people particularly like avoiding squandering money on distant, bloated bureaucracies. And we're seeing this around the country. I highlighted some examples, and you can go abroad, even in places that probably many Americans perceive as monolithic nationalized system like Sweden or Spain. It's actually governed at a local level. And they know that senior loneliness, or loneliness in general, has the health impact of being diabetic, obese, and smoking and drinking too much. Like it's that kind of impact. So, hey, how about rather than waiting for them to be a 5-alarm medical fire, why don't we address loneliness? Have community programs, have senior centers. These are the types of things that people are doing. And I think of it as this kind of next stage of economic development. And let me give you a little example. If economic development 1.0 was dumb luck, you're a transportation hub, you're a port city or something like that. 2.0 is, you throw some tax breaks at a company to attract or retain them, maybe put some marketing veneer on your community. But look at IBM. 10 years ago, over 10 years ago now, they saw this was the trend line. And they're competing with Infosys and Wipro and Tata, these Indian companies. And they're going, man, we've got to get control of our costs, but we also we're going to win on a high performance workforce. And so that's one of the reasons you've seen them be very active in investing in primary care and mental health services. This didn't become their future. They've been pretty guarded about what their actual figures are, but I know that, the folks who ran the medical side, this didn't happen. They stopped that from happening. Part of how they stopped it from happening is, if you look at this graph here, it's a little complicated, but it's a variation of probably we've seen. You've got longevity on the horizontal axis. You've got per capita spending. And so these kind of blue data points are from 1975. What was the longevity in these countries? How much were we spending? And then the red ones are what happened 30 years later. So, costs went up across the board, but also longevity in most countries went up. It went up in the US, but then we've actually backslid. I don't have more recent data, but we backslid. So we're actually getting worse while we're spending more. And so they went and looked at data from Dartmouth Atlas. Turns out Dubuque, Iowa is cost competitive. Ogden, Utah, cost competitive, because they focus on health and well-being and primary care, and there's sort of a healthcare system that's more under control. Guess where they moved 3,000 or 4,000 jobs? Dubuque, Iowa. It may not have been the obvious place for IBM to go, but they were very thoughtful about it. And so again, I think about not only that stimulus, but a different way of thinking about economic development. So for us, fundamentally, our social impact metric is we believe there's more than enough money sloshing around in a healthcare system that's just poorly allocated. And so we call it the Health Rosetta dividend. And we have some examples of, what organizations have done. A school district that's, freed up over the life of a K-12 cohort, $2 billion. Service center, they're able to put $1,000 into profit sharing that wasn't there before. Some really great examples. And this is really what we're measuring going forward. And then, as much as the dollars are nice, if you look at the health outcomes, once you have proper primary care and you go to high quality centers and just don't let the system run amok, the health outcomes, if it was in a pill, it would be the blockbuster drug of the century. It's such an improvement in outcomes. That's the nice thing here is, as I say, the best way to slash healthcare costs is to improve benefits. And that's what these organizations have done. So just to reiterate, we can fund these things from the current waste: clean air, clean water, lifelong education, daycare, walkability, parks, home retrofits. The Institute of Medicine had some infographics. It's amazing when you talk about $1 trillion of waste in healthcare. And if we actually put that towards productive parts of our economy, healthcare is the only industry that's hasn't seen productivity gains in 20 years. It's really kind of been off the rails. Then amazing things happen. And we think the time is right. In many communities, there's limited options. I mentioned the stimulus. Who knows more about local needs than locals? And certainly when it comes to health and well-being. And we've made life very difficult on doctors and nurses. There's record levels of burnout, even suicide amongst doctors and nurses. The number one driver of that is insurance bureaucracy. So, it's very common. There's data out there that says doctors, particularly primary care docs, are having to spend 2 hours on bureaucracy for every 1 hour patient time. That's a problem. And then we've got a lot of fraud. Well, when people are watching, kind of minding the store, right, versus folks that paradoxically, again, I don't have time now, but I go into the book, why fraud has actually been good for some organizations' business in the industry, sort of paradoxically. When you have people really watching it, this is half the battle, frankly, for employers, is just, essentially the insurance card has become the unlimited credit card. The same company will reject a restaurant expense item that has, for $70 is paying sight unseen 6-figure claims. So again, mindset shift is really important there. So that's where we think it's a really great time for it now. So wanted to leave some time for questions. My contact info is here. Happy to be, people reach out. If you go to this URL at the top of the screen, you can download the PDFs of my book for free. If you like them, you can buy them. That's fine. We just want the word to get out there. And the CEO's Guide was the first book. The Opioid Crisis Wake-Up Call is kind of the next edition of this with a different framing. Basically goes through and looks at the healthcare system through the prism of the opioid crisis. Sadly, as you dig into the full context of the opioid crisis, there's 12 major drivers I found. 11 of the 12 major drivers, employers, the key unwitting enabler. It's their dollars that have funded and fueled the opioid crisis. So I break that down. So if you're just going to read one book, I'd actually encourage you to read this one because pretty much the content here is in this one, but you can download them both if you want. And then I have the TED Talk that I mentioned earlier. So with that, happy to field any questions. I don't know, Matt and Shelley, I think you're gonna monitor those. So happy to take any of those questions, and I love tough questions. So look forward to that.
Right. Well, thanks, Dave. Shelley had some technical issues, so she's off for now. But I will ask some of the questions that we've had come through the text chat box here. So the first question we have relates to mental health, and the question was, what role does mental health care play in managing costs?
It's a big one, and it's not the easiest. I mean, there's some studies around it, but it's not the easiest one to measure. But that was I mentioned very briefly in the case of IBM, that's a very large, very sophisticated organization that has a lot of consulting, lots of clients. They had two MDs who were running their effort, and mental health was a big part of it. If you look at 50% of the opioid prescriptions, people have a diagnosed mental health condition. I'm sure not getting help right now with what's going on with the pandemic. So it's a big issue. It tends to ripple through everything. If you look at I'll give you an example from the opioid crisis wake-up call. Lower back pain. Second most common reason people go to the doctor. Number one driver of opioid prescriptions, number one driver of disability, zero evidence opioids are effective for lower back pain. And I bring up that example because there's an interplay where you can have a mental health issue. It may make you less apt to get up and move. That can lead to back pain, might lead to other, maybe weight issues that can exacerbate weight gain. And then we know studies from Starbucks did with Virginia Mason, 90% of the spinal procedures we do don't help at all. And that creates an issue. And then there's also some mental health issues manifest themselves as physical pain. And so you've got to have a good triage process. And that's where in places like Rosen Hotels, they've got mental health specialists and physical therapists in that primary care setting. So they can really suss out what's going on there. So it's an incredibly important issue. And when I talk about fully actualized primary care, I mentioned a couple of things. So not only doctors, nurses, the mental health, behavioral health specialists, PT, health coaches, often pharmacists. It's this wrap around, and then you don't have to shove people off, and take another half day off of work or whatever to deal with these issues. They can have the time to get at the root cause. So really great question, something I'm very passionate about.
All right, and we had a question relating to, you had talked a little bit earlier about direct primary care and the direct primary care model. We had a question that asks, we like the direct primary care model, but it takes up such a tiny fraction of our local market, at least here in Wichita. What should we look for high quality primary care in the more traditional non-DPC sense?
Yeah, I mean, there's multiple options. So, there's been this kind of chicken and the egg to some extent with DPC, where there's not as many DPC because there's not as many employers saying, we'll pay for it, even though we know primary care works really well. And so there's on-site, near-site clinics. So sometimes those are shared across multiple employers. You see places like Seattle, where there's a mix of on-site, near-site, and DPC. So the greater metro area, pretty much the entire area, you can get access to great primary care. You may have to piece it together with a few different ones, but in some ways that's not any difference. Most primary care aren't owned all by the same people. And then in some rural areas, you may have issues. And so virtual primary care can be actually very effective, particularly for a large part of the population. And the really effective ones, and it's much more than just telehealth, which deals with pink eye and urinary tract infections. Organizations like Sherpa have done that very well. Sherpa with 2 A's at the end. And there's I mentioned sometimes people say it's 5% consume 50% of the dollars. Well, then the flip side of it is 95% of the people consume the other 50%. And so virtual primary care can work there. And then when people need to get a face-to-face, and certainly we're seeing during the pandemic, and I'd said this countless times over the last several years, when you actually talk to docs, they'll say, yeah, 70% of the time you don't need to come in. We just force you to come in because that's the only way we get paid. Who can blame them? Now we're seeing with the pandemic, that's true, right? Most of the stuff doesn't require a face-to-face hands-on, and certainly some things like mental health don't require hands-on at all. So there's a number of ways you can do that. Basically, if you want to get primary care, you can get it. And there's even some pretty interesting text-based on-demand primary care. You know, that when this COVID thing started, we had an advisor in our program that their business, he was working with a business that runs nursing homes for vets, and they were very worried about what's going on there. And some of those areas were rural area, they didn't have direct primary care, and their carrier basically said, okay, yeah, we have this, but you know, it's not going to be available till basically now. You know, it was mid to late May, and this was over 2 months ago, and it was pretty expensive. Whereas the organization I connected them with, in a week, they not only had made contact, they were fully up and running. So that's one of the advantages of things like virtual primary care.
All right. So Dave, you had mentioned a couple times about the status quo in the world that we live in now. And there's a question about if there's any strategies used, whether it's coalitions or employers talking to their leadership to, with their decision makers, to overcome the quote unquote status quo bias, where somebody would rather stay in something that they know is not as good for them instead of switching to something that is more than likely better for them, but would take a big change. What are some good strategies you could employ in those types of situations?
Yeah, I mean, in some ways, it's not that different than what they've done in other areas of their company. And change management is significant, right? When you change how you approach supply chain, you change how you do your marketing process. And this is even more, right? Because it affects people and their family. And so that's one of the things that if you email me, I can send you a link to a series. It's actually going to be my next book on change management and some of the tactics that people have used at each step. You know, I use Philip Kotter's model. It's an 8-step process that's quite well proven. And, you know, how do you create, you know, a sense of urgency and a demand for change and a vision, and how do you root it into culture and these sort of things that you need to be thoughtful about. Now, as I mentioned, those steps that I went through, most of those don't actually impact the member. You know, you change your PBM, you can still go to the same pharmacies. Although in some cases they'll create incentives for maybe a local independent pharmacy. So a lot of those things don't have to actually impact the member. And I think that's usually the biggest trepidation. And you'll see various things that are the flavor of the month or are really hot, like reference-based pricing is very hot right now. To me, it's just kind of a bridge to a more rational thing. And it is the one that has the risk if you don't do it well. And so we have, you know, there's a lot of guidance on how to do that well. I hit the highlights. But you take like the primary care thing, like if you look at some of the union environments that have done this, pipe trades, the New Jersey public employees, city of Kirkland, 6 of their 7 unions were on board right away. They actually started with primary care because it's clearly a positive value add. And again, you know, if you have enough critical mass, if you're doing an on-site or near-site clinic. And so you pick some wins, you know, and that's definitely one of the things of the change management process. Get some things that are some wins, some things that remove pain, put more money in their pocket. And, you know, at our last summit, I can, again, if you email me, I can send you a link. One of our advisors, we recorded him kind of simulating an employee education session. This was at a, you know, kind of working class employer. I think it was either in Ohio or Kentucky. You know, he just basically did some high level education on what's going on, and people understood, oh, that's what's going on. That's why I haven't gotten a raise forever. And so a little bit of education goes a long way, but again, I can send you the series that I did on change management that goes into it in more detail.
That would be great. Our next question is actually in this same vein of a question, and it has a little bit of a lead up to the question, so I'll read it as the person posted it. So employers have enabled the addiction to higher and higher pricing. There are reasons the person most responsible for the health plan, which is the benefits director, is not as motivated to change the status quo, namely lack of support from the C-suite. Why do you think the benefits directors are not getting support change happens. CEOs of Fortune companies, what is the reason they have so far refused to get involved?
Well, there's a few dynamics going on there. It starts with they're very overburdened themselves. I mean, they are often responsible for a lot of compliance and recruiting and HR systems, and generally what they've been told by their CEO, starting decades ago, was keep our people happy, don't get us sued. That's not, and then if people aren't really, super analytic or hard drivers on change, that's not necessarily a good set of ingredients for driving the change. And at the same time, a lot of them have been given information like, "Ooh, it's scary." And in the tech industry, where I spent a lot of time, the term that's used is fear, uncertainty, and doubt. Right? That's how you freeze status quo. And so it's very easy to use fear, uncertainty, and doubt to freeze status quo. And so it's just this whole combination of things that plays out. And until the CEO or somebody in the senior level has the back of the benefits director, change won't happen. And now the benefits director may be the one who gets, champions the cause and says, look, we've got this calculator on our site, healthrosetta.org/CFO. We put in some high level numbers. It's kind of a simplified calculator of how much you'd have to increase sales revenue to have the same impact of if varying levels of how aggressive you get on reforming your health plan, and what the impact is. So numbers matter. In the case of IBM, they got the buy-in from the CFO around the ROI on mental health and primary care. So when they had the meeting with the CEO and the executive team, because this is a big deal, there are hundreds of thousands of people worldwide, the CFO was absolutely with them. And it's like, yep, I scrutinize these numbers, they're real. And so it's those combination of factors. And, of course, none of us would wish the COVID scenario was happening. But it is bringing, people have said for years, gosh, you guys are really going to take off when there's a recession. And I never liked hearing that. I understood their point, but that's what we're seeing now, right? There's, employers are very challenged. You get into the public sector, there's no way counties, transit authorities, cities, school districts can avoid cutting staff and services without tackling healthcare. There's just no way if you look at what's going on in the economy. And so necessity is the mother of invention. If you look at a lot of the organizations that have done it, they're low margin businesses or budget constrained businesses. So, we don't spend a lot of time worrying about Facebook. They can be sloppy on their benefits. I don't know if they are or not, but just give you an example of a highly profitable company. That's not where we've seen the action. If you go back and look through the logos, you'll see a lot of manufacturers, retailers, hoteliers, public sector entities, a lot of just regular American, type of jobs.
I am so sorry. I am back on.
Nope.
This is Shelley again.
No problem.
We had everything went south, and everyone in our house couldn't work there for a few minutes. I am so sorry. So, and I couldn't get in on the phone, so I do apologize.
No problem. We all stayed on, so
I know.
Missed some of the party, but we were okay.
Yeah, and I'm glad that we have this recorded so that I can go back and listen to what I missed. But anyway, I think we are about done with our time, and I think according to Matt, who stepped in for me, thank you so much, Matt, and had the questions answered. I just want to thank you again, Dave, so much for this presentation. It was I was really interested, and I had a number of questions, but I will ask those to you later. And again, just want to thank you so much. I also want to remind everybody, at least the members of the Kansas Business Group on Health, that we do have some upcoming events. We will be having our monthly HR forum on May the 26th, and we'll be having those monthly from here on out to the end of the year. Those will be virtual. And we will have our annual healthcare roundtable on July 22nd. That too will be virtual, and you'll be getting information about that. So again, I want to thank you, Dave. I want to thank everybody who attended. And if there's nothing else, then anything else you wanted to add, Dave?
No, just look forward to your questions and anybody else's. And you know, I guess my parting thought is the cavalry's not coming from DC to fix healthcare. It's on us, and it is doable. So it just takes will. And you know, it's change, but the payoff is tremendous.
Well, that is obvious, and I appreciate you helping lead the charge in that, because we definitely need that. So anyway, and I'm partway through your latest book, so if I'm sure you probably mentioned that more when I was offline here, but anyway, I would recommend it to you or to everyone on the webinar here. So okay, well, thank you so much, everybody, and stay safe and take care and enjoy the rest of your day.
Thanks, Shelley.
Thank you. Bye.